Imagine for just a split second that you try to pick up your morning coffee, but your arm just, well, it doesn't quite do what you expect. Feels a bit distant, almost. Not yours. That really unsettling disconnect, right? Where your own limb seems to have a mind of its own. Ever had that fleeting feeling?
Uh-huh.
Today, we're plunging into a world where that feeling, well, it doesn't just vanish. We're taking a deep dive into hemiplegia. It's a pretty significant neurological condition.
Right.
And it's not just some temporary inconvenience. It involves paralysis or paresis that's a noticeable weakness affecting one arm and one leg, both on the same side of your body.
Yeah, it's a major challenge for people who experience it.
Absolutely. And we've got a really comprehensive set of materials today, basically excerpts from medical texts that cover, well, pretty much everything from the basic definition right through to the nitty-gritty details of causes, how it progresses, the different forms, potential complications,
Right.
how it's investigated, treatments, the whole spectrum, really. Exactly. So our goal, our mission for this discussion is to give you a clear, thorough understanding of hemiplegia, explore all those different facets and, see what it reveals about our nervous system, how amazing it is, but also how vulnerable it can sometimes be.
It's truly remarkable, isn't it? How a condition affecting seemingly just one side's movement can tell us so much about the brain's complex control systems.
It really is. Now, before we dive headfirst into the details, we want to give a special thank you to London Heartbeat's Z Academy UK.
Hear, hear.
Their generous educational support helps make resources like these accessible. And if you're keen to explore, they have over 150 popular courses, and you want to stay informed with more discussions like this one, definitely check out their social media. They're on Facebook, Instagram, and YouTube for free, regular updates.
Yeah, definitely worth a look. Lots of great stuff.
You really won't want to miss out on future deep dives. Okay, so let's map out our journey. We need that solid foundation first, the definition of hemiplegia. Then we'll look at the different ways it can show up, dig into where it actually starts in the nervous system, understand how doctors figure it out, the diagnosis, and finally cover the approaches to managing it. Sound good?
Sounds like a plan. Let's start with the basics defining hemiplegia.
Okay.
Right, so at its core, as we said, hemiplegia is that paralysis or weakness affecting an arm and a leg on the same side. Now, the text immediately highlights something crucial when talking about upper motor neuron lesions, or UMLN.
UMLN, okay.
The relevance of a lesion being above C5. C5 refers to the fifth cervical vertebra, in your neck.
Yeah.
So when we talk UMLN in hemiplegia, it usually means damage in the brain or the spinal cord above that C5 level.
Okay, above C5. Why is that distinction important? And what's the difference between this UMLN and, what was the other one, LMLN?
Exactly. LMLN, lower motor neuron lesions. Understanding the difference is key to figuring out why hemiplegia looks the way it does.
Right. So the sources explain UMLN involves damage happening before the signal gets to a key nerve cell in the spinal cord, the anterior horn cell.
Think of it like a relay station.
Yeah, our relay station. So UMLN damage is like an issue higher up the command chain, maybe in the brain's instructions. But LMLN damage, that's at or after that relay station, right down the line towards the muscle itself.
Precisely. It's like a problem in the wires closer to the muscle,
Yeah.
stopping the message getting through properly.
Okay, so command issue versus local wiring issue. That makes sense.
And the source material has this great table comparing the features you see depending on whether it's a UMLN or LMLN causing the weakness. Let's start with paralysis.
Okay.
In a UMLN, if the damage is before the pyramidal decussation, that's the spot in the brainstem where the main motor nerves cross over.
Ah, the big crossover point.
Right. If the damage is before that crossing, the paralysis is on the opposite side of the body. But if the UMLN is after the crossing, the paralysis is on the same side as the lesion.
Okay, that's crucial. And LMLN.
LMLN damage, so at or below that anterior horn cell, always causes paralysis on the same side as the damage. No crossing involved at that level.
Got it. That immediately explains why, say, a stroke on the left side of the brain often causes weakness on the right side of the body. It's that pyramidal decussation.
Exactly. That crossing is fundamental.
What about the muscles themselves? Do they waste away differently?
Absolutely. That's another key difference. With UMLN, you generally don't see significant muscle wasting early on. Maybe later, just from not using the limb that's disuse atrophy.
Right. Makes sense.
But with LMLN, where the nerve supply directly to the muscle is cut off, you see noticeable muscle wasting much earlier. The muscle just isn't getting the signals to maintain its bulk.
Yeah. No signal, muscle shrinks. Makes perfect sense. What about reflexes? Doctors are always tapping knees and elbows.
Reflexes are very telling. In UMLN, you often get hyperreflexia. The reflexes are exaggerated, stronger than normal.
Like the brakes are off.
Kind of, yeah.
Yeah.
The inhibitory signals from higher up are disrupted. But in LMLN, you typically see hyperflexia decreased or even absent reflexes because part of that reflex arc, the lower motor neuron itself, is damaged.
Okay, so brisk reflexes point up, sluggish or absent reflexes point down towards the muscle end. What about muscle tone? Stiffness versus floppiness.
That's tone, yeah, the resting tension. UMLN usually causes hypertonia, increased tone, stiffness. Spasticity, that kind of jerky resistance, is a type of hypertonia,
Right, I've heard that term spasticity.
whereas LMLN usually leads to hypotonia, decreased tone. The limb feels floppy.
Okay, recap. UMLN often means increased tone, stiffness, spasticity. LMLN often means decreased tone, floppiness.
Got it.
And the last one in that table, the Babinski sign, striking the foot.
Ah, yes, the plantar response. Crucial one. In UMLN, you often see a positive Babinski sign. The big toe goes up, and the other toes might fan out.
Which is normal in babies, but not adults, right?
Exactly. In adults, it signals an upper motor neuron pathway problem. In LMLN, you'd get a negative Babinski, the normal adult response where all the toes curl downwards.
Wow. Okay, so that table really gives clinicians a powerful starting point for figuring out where the problem might be located.
It's a fundamental toolkit, definitely.
Okay, so let's shift gears. What actually causes hemiplegia? The etiology. The sources say issues with blood supply, vascular problems are the big ones.
That's absolutely right. Vascular causes are top of the list. And within that, there are a few main ways it happens. First, thrombosis.
A blood clot forming right there in the brain artery.
Exactly. And a major factor behind that is often cerebral atherosclerosis, hardening and narrowing of those arteries.
Yeah.
Makes it easier for clots to form and block the flow.
So those narrowed, stiff pipes are prime spots for blockages.
Precisely. Then you have embolism.
That's when a clot travels from somewhere else.
Right. A clot, or maybe plaque, breaks off from somewhere else, often the heart, especially if someone has conditions like mitral stenosis, or they've had a heart attack, myocardial infarction, or have atrial fibrillation.
Okay, fib.
Yeah. Or the clot can come from the carotid arteries in the neck. It travels through the bloodstream and gets lodged in a smaller brain artery. Blocks it up.
Wow. So a heart problem or a neck artery problem can directly cause a brain problem leading to hemiplegia. Okay, what's the third vascular cause?
Hemorrhage. Bleeding.
Bleeding in the brain.
Yes. This can happen due to various things. Hemorrhagic blood diseases like purpura. Chronic high blood pressure hypertension weakens vessel walls over time.
Making them likely to burst.
Potentially, yes. Also, aneurysms, those weak, bulging spots on vessel walls. Arteriovenous malformations, or AVMs, tangles of abnormal vessels. And of course, head trauma.
So blockages or bleeds both disrupt the brain's blood supply and can cause damage leading to hemiplegia. The source also had that table comparing thrombosis, embolism, and hemorrhage based on how they present, right?
Yes, super useful for clinicians trying to figure out the likely cause of a stroke, which often leads to hemiplegia. It compares them based on things like age, onset, warning signs, vomiting, consciousness, convulsions, heart conditions, blood pressure, CSF results, and CT/MRI findings.
Okay, let's break that down. Age.
Generally, thrombosis and hemorrhage are more common in older folks. Embolism can happen across a wider age range, sometimes even younger people.
And onset. How quickly do symptoms start?
Thrombosis tends to be more gradual, minutes to hours. Embolism is usually bam, sudden, dramatic. Hemorrhage is also typically very abrupt.
Any warning signs beforehand? A prodrome.
Maybe some with thrombosis like brief weakness spells, but usually none with embolism or hemorrhage. They tend to hit out of the blue.
What about feeling sick, vomiting, and consciousness?
Vomiting isn't that common with thrombosis or embolism, but more frequent with hemorrhage, probably due to the sudden pressure increase in the head. Consciousness is usually okay initially with thrombosis and embolism, but with hemorrhage, especially a big one, people can lose consciousness quickly, even go into a deep coma.
Okay. And convulsions, seizures.
Pretty rare with thrombosis and embolism.
Yeah.
More common with hemorrhage, especially if it involves the ventricles or there's underlying high blood pressure.
What about underlying conditions? Heart problems? Blood pressure?
Pre-existing heart disease like AFib, previous heart attack, valve problems strongly points towards embolism. Hemorrhage is more linked to existing high blood pressure and certain heart changes like ventricular hypertrophy. Blood pressure might be high in thrombosis, usually normal in embolism, but typically very high in hemorrhage.
And the diagnostic tests, CSF scans.
Cerebrospinal fluid CSF is usually clear in thrombosis and embolism, but in hemorrhage it might be cloudy or bloody. On CT or MRI scans, thrombosis and embolism often show up as hypodense darker areas, indicating tissue damage from lack of blood flow. Hemorrhage typically looks hyperdense brighter because of the blood.
That table really paints a clear picture of the differences. Now, besides these big vascular causes, the source mentioned other possibilities.
Yeah, important not to forget those, even if they're less common. Congenital conditions like cerebral palsy brain damage from before or during birth can cause hemiplegia from a very young age. Trauma, obviously, direct injury can cause it. Inflammatory conditions too, things like meningitis, inflammation of the brain coverings, or encephalitis, inflammation of the brain itself.
Infections causing it.
Yes. And neoplastic causes brain tumors, pressing on or damaging motor pathways. And finally, degenerative conditions, like multiple sclerosis, where the nerve insulation breaks down.
So while blocked or burst blood vessels are the usual suspects, there's a whole range of other things that can lead to hemiplegia. It really shows how many ways the nervous system can be affected. Okay, let's talk about how hemiplegia might change over time. The stages.
Right, the source describes two main stages. First is the stage of shock, or flaccid paralysis.
Flaccid meaning limp?
Exactly, limp, floppy.
Yeah.
This stage happens more often when the onset is sudden, like with an embolism or trauma. Might not happen at all if it develops gradually, and its duration varies hugely. Seconds, minutes, sometimes even months.
Months. Wow. And if it lasts longer, that's not a good sign.
Generally, yes. A prolonged flaccid stage often suggests a more severe initial injury and maybe a tougher road to recovery. Interestingly, during this shock phase, even if the cause is an UMLN, like a stroke, the limbs often look like they have an LMNL low tone, reduced reflexes.
But the Babinski sign.
Ah, good point. The Babinski is usually positive, which points back to the UMLN origin.
Okay, so an initial floppy stage, despite the problem being higher up, what's the next stage?
The stage of spastic paralysis. This is the more established chronic phase. Here, the limbs show those classic UMLN signs we talked about, hypertonia, so increased tone, spasticity.
Stiffness, exaggerated reflexes.
Exactly, hyperreflexia.
And this spasticity, it affects muscles differently.
It does. It tends to hit the distal muscles harder, hands and feet, more than the proximal ones like shoulders and hips. So skilled movements, fine motor control with fingers and toes often take the biggest hit.
Makes sense. Those need precise control. And the pattern of weakness, flexors versus extensors.
Yes, there's a typical pattern. In the upper limb, the extensors muscles that straighten the arm and wrist tend to be weaker than the flexors that bend them. So the arm often ends up held in a bent position.
Okay.
In the lower limb, it's generally the opposite. The flexors bending the hip and knee are weaker than the extensors that straighten them. Contributes to that stiff-legged walk you sometimes see.
Right. So that transition from floppy to spastic with those specific patterns is pretty characteristic of UMLN hemiplegia. Now, the source also talks about different levels of hemiplegia. Where the damage actually occurs makes a difference to the symptom.
A huge difference. The location is critical. The source starts with cortical hemiplegia, damage to the cerebral cortex, the brain's outer layer.
And this often starts as weakness in just one limb, not the whole side, monoplegia.
Often, yes.
Yeah.
Contralateral monoplegia. It's thought to be because the motor neurons, the BET cells in area 4, are spread out a bit. So a small lesion might just hit the arm area or just the leg area initially.
And sometimes seizures beforehand.
Yeah, the source mentions a history of convulsions might happen before the paralysis, suggesting irritation in that motor area. And if the lesion's large, coma is possible.
And because it's the cortex, are there often other problems besides the weakness? Thinking, sensation, language?
Definitely. Cortical lesions can bring other cortical manifestations on the opposite side. Things like sensory loss, aphasia, trouble with language, producing it or understanding it, or homonymous hemianopia, losing half the visual field in both eyes.
Okay, so cortex damage, wider impact. What about subcortical hemiplegia, below the cortex?
This involves the white matter tracts beneath the cortex. The paralysis is still contralateral, opposite the lesion, but often more extensive from the start, affecting arm and leg more fully. Interestingly, coma and convulsions are usually less common or severe than with cortical lesions.
Maybe because it disrupts the descending pathways more globally, but without that direct cortical irritation.
That seems plausible. Then we have capsular hemiplegia, damage to the internal capsule.
That's like a super busy highway for nerve fibers, right?
Yep. Exactly. A really compact area carrying loads of motor and sensory info. So damage there has big consequences.
Leading to?
Typically complete hemiplegia right from the start, arm and leg on the opposite side, often with hemianesthesia, sensory loss on the same side as the paralysis. Homonymous hemianopia is also common.
But not the coma or convulsions like cortical.
Generally, no coma, no convulsions, no aphasia, unless it's a massive lesion that spreads. But it does mention specific facial and tongue weakness, lower face weakness on the opposite side, and the tongue deviating towards the paralyzed side when stuck out.
Why the lower face and tongue specifically?
It's about the nerve supply. Most cranial nerve muscles get input from both sides of the brain, but the lower face muscles, via cranial nerve 7, and tongue muscles, cranial nerve 12, get mainly contralateral input. So a capsular lesion knocks out that main supply.
Fascinating anatomical detail. Okay, next level. Brainstem hemiplegia, also called crossed hemiplegia. That name sounds intriguing.
It is. You still get the hemiplegia, arm and leg weakness on the side opposite the brainstem lesion. But the crossed part is you also get cranial nerve problems on the same side as the lesion.
Wait, so weakness on one side of the body, but facial problems on the other side, relative to the lesion.
Exactly, because the lesion hits the cranial nerve nuclei on the same side within the brainstem, and it hits the descending motor tracts before they fully cross over to control the opposite limbs.
A mix of same side and opposite side signs.
Okay.
And which cranial nerves are affected depends on where in the brainstem the damage is. Midbrain, pons, kilo?
Precisely. The source breaks it down. A midbrain lesion.
What happens there?
Ipsilateral third and fourth cranial nerve palsy. So same side as the lesion. Think eye movement problems, maybe a droopy eyelid, dilated pupil, plus contralateral hemiplegia.
Okay. And a pontine lesion in the pons.
Ipsilateral fifth, sixth, and seventh nerve palsies. So same side, facial sensation loss, chewing muscle weakness, inability to move the eye outwards, and facial muscle weakness. Again, with contralateral hemiplegia.
Right. And finally, a medullary lesion.
Ipsilateral 9th, 10th, 11th, and 12th nerve palsies, affecting swallowing, voice, maybe shoulder shrugging, and tongue movement on the same side, plus the contralateral hemiplegia. This cross pattern is a dead giveaway for a brainstem problem.
It's like a diagnostic roadmap right there in the symptoms. Okay, last level, spinal hemiplegia. How's that different?
Very different pattern, often called Brown-Séquard syndrome, usually from injuring one half of the spinal cord. Here, the hemiplegia, the motor weakness, is on the same side as the spinal cord lesion.
Same side weakness, okay.
But you get loss of pain and temperature sensation on the opposite side, starting a bit below the lesion level. Touch, vibration, position sense, often lost on the same side as the weakness.
Wow, that's a specific mix. Motor loss on one side, pain temp loss on the other. Very distinctive for a spinal cord issue. So we've seen how damage from the cortex down to the spine leads to different hemiplegia patterns. Complex stuff. Now, the source talks about complications from just being stuck in bed, which happens a lot initially.
Yeah, prolonged immobility is a real risk factor for secondary problems. The source lists psychosis, stress, isolation, maybe brain effects. Bed sores, pressure ulcers from lying too long in one spot.
Nasty ones, those.
Definitely. Deep vein thrombosis, DVT, blood clots in the leg veins from poor circulation.
Serious risk.
Very. Muscle wasting, disuse atrophy, we mentioned that. Urine retention, often functional, not a blockage. Constipation, common with inactivity. And aspiration pneumonia.
Breathing in food or fluids.
Yeah, a major risk if swallowing is affected or consciousness is low. These really highlight why good nursing care, moving the patient and starting rehab early, is so crucial.
Absolutely critical to prevent things getting worse. Okay, how do doctors investigate the cause? What tests?
Key investigations include CT scans and MRI scans of the brain. Essential for seeing the brain tissue, finding the lesion. Is it a stroke, bleed, tumor? Where is it? What type?
Brain imaging first. What else?
If they suspect an embolism, an echocardiogram, ultrasound of the heart is important to look for clot sources there.
Makes sense.
And Doppler ultrasound of the carotid arteries in the neck, checking for blockages there that could send clots to the brain.
So tailored tests depending on the suspected cause, heart, neck arteries. The source also mentions leading causes of death after stroke, which is a big cause of hemiplegia.
Yeah, and it's often not the stroke itself directly, but complications. Pneumonia, often aspiration pneumonia. Pulmonary embolism, a clot traveling to the lungs. And, perhaps surprisingly, ischemic heart disease.
Underlying heart problems catching up.
Likely reflects shared risk factors, yeah. Stroke and heart disease often go hand in hand because of things like atherosclerosis.
A sobering reminder. There was also a note about checking cranial nerves carefully in hemiplegia. How does that help?
It's great for localization. If there's hemiplegia but zero cranial nerve involvement, the lesion is likely in the spinal cord.
Below the brainstem where cranial nerves live?
If the only cranial nerves affected are the lower 7th face and under 12th tongue, often points to capsular hemiplegia.
Because of that specific contralateral supply we discussed.
Exactly. And if a cranial nerve shows LMNL signs, weakness on the same side as the nerve damage, and that's on the opposite side of the body from the hemiplegia, that strongly suggests brainstem hemiplegia, the cross pattern.
Brilliant clinical clues.
Uh-huh.
Okay, let's move to the crucial part. Treatment.
Treatment is really multifaceted. Depends on the cause, the stage, how severe it is, the patient's overall health. The source breaks it down. First, if the patient is comatose, general care is paramount.
What does that involve?
Meticulous supportive care. Frequent turning in bed to prevent pressure sores, balanced nutrition, maybe via tube feeding, bladder care, often needing a catheter, bowel care, maybe enemas to prevent constipation, and crucial respiratory care, keeping the airway clear. Oxygen is needed, suctioning secretions, antibiotics to prevent chest infections or pneumonia.
Just keeping the body going and preventing those complications we talked about. What about more direct medical treatments?
There's symptomatic treatment, things like cerebral dehydrating agents, mannitol, Lasix to reduce brain swelling, antiemetics for nausea, antipyretics like paracetamol for fever, sedatives if needed for agitation, and muscle relaxants to help manage spasticity later on.
Okay, managing the immediate fallout. What about rehab? Physiotherapy must be key.
Absolutely vital. Physiotherapy starts early. Initially, passive exercises therapists, moving the limbs to keep joints mobile, prevent contractures. Careful positioning of limbs is also important.
Right.
Then, as recovery happens, it progresses to active exercises, strengthening, coordination, balance, retraining walking, using the affected arm. It's a long process.
And blood pressure. The source said something interesting about not lowering it too much right after an ischemic stroke.
That's right. It's a bit counterintuitive. The acute phase of an ischemic stroke, a blockage moderately high BP, can actually help push blood to the salvageable brain tissue around the damaged core, the penumbra.
So lowering it too fast could be bad.
Potentially. The source says antihypertensives are usually only given if the pressure is extremely high, like systolic over 220 or diastolic over 140. It's a delicate balance initially.
Fascinating. Okay, now for specific treatment targeting the actual cause.
Right. For ischemic stroke, blockage, thrombolytic therapy, clot-busting drugs like TPA can be an option, but there's a very tight time window, ideally within 3, maybe 4.5 hours of symptoms starting.
Time is brain.
Or as the source says, time is a lot of brain. And there are strict contraindications, no bleeding, recent surgery, super high BP, so actually relatively few patients qualify.
Shame, but crucial when it works. What about anticoagulants, blood thinners?
Anticoagulants like heparin or warfarin are mainly for embolic strokes, clots from the heart, usually. Prevent more clots forming, again, contraindicated if there's high bleeding risk.
And antiplatelets, like aspirin.
Antiplatelets, especially aspirin, are recommended for almost all ischemic stroke patients. They make platelets less sticky, reduce clot formation, lower recurrence risk, and improve survival.
Okay. What if it's a hemorrhagic stroke? Bleeding. Totally different approach.
It's completely different. Goal is stop the bleed, reduce pressure. Surgical evacuation of the blood might be possible if it's accessible. Antifibrinolytics might be used cautiously sometimes to stabilize the clot, but absolutely no clot busters or anticoagulants that would make the bleeding worse.
Makes total sense. The source also mentioned neuroprotective agents. Do they work?
Yeah, things like serbalicin, Trental, Neutrophil have been tried, aiming to protect brain cells. But the source clearly states they have not been proven effective. Still searching for good neuroprotective drugs.
Good to manage expectations there. Okay, the source briefly revisits the cerebral cortex areas. We touched on this, but maybe a quick reminder of key areas.
Sure. Frontal lobe has the motor cortex, area 4. Damage causes contralateral weakness. Parietal lobe has the sensory cortex, areas 1, 2, 3. Damage causes sensory loss. Temporal lobe involved in hearing, memory, language comprehension, Wernicke's area. Occipital lobe has the visual cortex, area 17. Damage causes visual field cuts like hemianopia.
And language areas.
Broca's area, 44, 45. In the frontal lobe for speech production. Wernicke's, often 39, 40. In the temporoparietal for comprehension. Damage causes different aphasias. Plus other potential issues like agraphia, writing, apraxia, performing movements, alexia reading.
So the hemiplegia often comes with a package deal depending on where the cortical damage is. Next, the blood supply of the brain, crucial for understanding stroke patterns.
Absolute key. 2 main systems. Anterior circulation from the carotid arteries branching into the anterior cerebral artery, ACA, and the big middle cerebral artery, MCA. Posterior circulation from the vertebral arteries merging into the basilar artery, which gives off the posterior cerebral arteries, PCA.
And each supplies specific territories.
Right. ACA feeds the medial parts of frontal parietal lobes. MCA supplies the lateral surface's huge area, including motor sensory for face, arm, leg, plus language areas. PCA supplies occipital lobe, vision, and medial temporal lobe.
So blocking different arteries gives different stroke patterns.
Exactly. ACA occlusion. Leg weaker than arm, face, maybe behavioral changes. MCA occlusion most common. Face, arm, weaker than leg, often aphasia if it's the dominant side. PCA occlusion. Primarily visual field loss. Hemianopia. And don't forget, the internal capsule supplied by small branches of MCA and others. Strokes there can cause pure motor or sensory deficits.
And those specific syndromes from blocking smaller brainstem or cerebellar arteries?
Yeah, like anterior spinal artery syndrome, weakness, pain temp loss below, PICA or Wallenberg syndrome, vertigo, swallowing issues, cross-sensory loss. ASEA syndrome, superior cerebellar artery syndrome. Each has a unique footprint based on the specific structures losing blood supply.
Really intricate vascular anatomy. The source then mentions vaso-occlusive syndrome, highlighting the MCA again.
Just emphasizing that middle cerebral artery occlusion is the most frequent type of stroke, given the large territory it supplies. It can affect cortical branches, deep branches to the capsule, or the main stem, leading to various patterns of hemiplegia and other deficits.
Understood. Now, what about temporary weakness, causes of transient hemiplegia?
Right? Weakness that comes and goes. Top of the list. Transient ischemic attacks, TIAs, or mini-strokes, temporary blockage. Symptoms resolve within 24 hours, often much faster. Big warning sign for stroke.
Okay, TIAs. What else?
Epilepsy, sometimes weakness after a seizure, called Todd's paralysis. An aneurysm might cause transient pressure effects. Hysterical paralysis, now often called functional neurological disorder. Hypertensive encephalopathy, sudden severe high BP affecting the brain. Migraine, specifically hemiplegic migraine, and relapses in multiple sclerosis.
So several possibilities for temporary weakness. The source then goes into more detail on stroke itself.
Defining it again, sudden neurological deficit, vascular origin, lasting over 24 hours or causing death. Third leading cause of death after heart disease and cancer. Major issue.
And the two main types, again?
Ischemic blockage, about 85%. Caused by thrombosis, embolism, sometimes blood disorders, arteritis, dissection, and hemorrhagic bleed, about 15%. Intracerebral or subarachnoid hemorrhage.
Risk factors for ischemic stroke, mostly atherosclerosis risks.
Pretty much. Modifiable ones.
Yeah.
High BP, cholesterol, diabetes, smoking, obesity, inactivity. Non-modifiable. Age, family history, race. And having TIAs is a huge risk factor.
Clinical features of ischemic stroke depend on the artery hit.
Entirely. MCA, face, arm, leg weakness, maybe aphasia. ACA, leg, arm, face weakness, maybe behavioral changes. Vertebrobascular, dizziness, double vision, balance problems, widespread weakness, numbness, altered consciousness, plus those specific brainstem syndromes like Pico-Wallenberg.
And the stroke progression. Flaccid then spastic.
Usually, yes. Initial flaccid stage, then evolves to spasticity. Often negative symptoms, loss of function. Onset is rapid, max deficit within minutes to hours. Usually it's older folks, and most have at least one vascular risk factor.
Investigations, blood tests, ECG, but imaging is key.
Crucial. Initial bloods, ECG. But non-contrast CT brain as first-line imaging rules out mimics, distinguishes ischemic versus hemorrhagic. MRI is more sensitive early on. Echo of suspecting heart source. Carotid Doppler for neck arteries, maybe angiography if surgery is considered.
Treatment mirrors hemiplegia treatment. Supportive care, rehab.
Yes, plus specifics. Carotid endarterectomy surgery for severe stenosis if eligible. Careful BP management. Thrombolytics if in the window. Anticoagulants for emboli. Antiplatelets like aspirin for almost everyone. Neuroprotectives still not proven effective.
Prognosis is variable.
Vary. Depends on size, location, age, other health issues.
Yeah.
Early improvement is good. Impaired consciousness, APHEs, severe brainstem signs are poor prognostic factors. Complete recovery is uncommon.
A tough outlook often. Okay, shifting to hemorrhagic stroke again.
The 15%. Intracerebral hemorrhage, ICH, or subarachnoid, SAH. Primary ICH often linked to chronic hypertension weakening small vessels. Secondary ICH from ruptured aneurysm, AVM, trauma.
How does ICH present?
Often hits during activity. Abrupt onset. Signs of increased intracranial pressure. Sudden severe headache, vomiting, maybe loss of consciousness. Seizures can happen. Specific signs depend on location.
And location matters. Where's most common?
Cudamen, basal ganglia, is most common. Then lobar, thalamus, cerebellum pons. Each gives different signs. Putamen, contralateral weakness, sensory loss. Cerebellum, headache, vertigo, vomiting, ataxia. Pons, often catastrophic coma, quadriplegia, Breathing issues.
Diagnosis. Clinical picture plus imaging.
Clinical picture, sudden onset, headache, vomiting, high BP, is suggestive. Brain CT is the key diagnostic test, shows the blood clearly. MRI can add detail. Lumbar puncture used cautiously. Blood tests for clotting issues.
Prognosis for ICH.
Can be grim. About a third die within the first month, often from high intracranial pressure or brainstem compression. But survivors can actually recover function surprisingly well as the bleed pushes tissue aside rather than destroying it like an infarct does.
An interesting difference. Treatment, no clot busters, obviously.
Right? General supportive care, maybe surgical evacuation of the clot if feasible, careful BP control. Different approach than ischemic stroke.
Okay, let's briefly revisit transient ischemic attacks, TIAs.
The mini-strokes. Brief episodes, neurological symptoms resolve fully within 24 hours, usually much less. If longer, but still resolves, sometimes called RIND, reversible ischemic neurological deficit. Huge warning sign for future stroke.
Caused by the same things as ischemic stroke. Thrombosis, embolism.
Yes, temporary blockage. Clinical picture depends on the artery-affected carotid territory. One-sided weakness, numbness, speech issues, transient vision loss in one eye, or vertebrobasilar territory, dizziness, double vision, balance issues.
Investigations and treatment similar to stroke.
Investigations are similar, aimed at finding the cause and risk. Treatment focuses on prevention, antiplatelets, aspirin, clopidogrel, sometimes anticoagulants, aggressive risk factor management, BP, diabetes, cholesterol, smoking, maybe surgery, endarterectomy, or angioplasty if there's significant carotid stenosis.
Crucial to take TIAs seriously. Now, paraplegia, how's that different from hemiplegia?
Paraplegia is weakness or paralysis of both lower limbs. Hemi means half, one side. Para means alongside both legs, usually due to bilateral UMNL or LMNL affecting leg pathways.
Causes, mostly spinal cord.
Spinal cord injury is the most common: trauma, tumor, infection, compression. Less often, brainstem lesions hitting both descending tracts, or rarely, bilateral cerebral lesions affecting leg motor areas.
Clinical features depend on the spinal level.
Yes. At the lesion level, maybe LMNL signs, flaccid, wasting. Below the lesion, usually UMNL signs, spasticity, hyperreflexia, Babinski. Sensory loss patterns can differ, intramedullary versus extramedullary. Bladder bowel dysfunction is very common.
Investigations, X-ray, CT, MRI, spine, treatment.
Yes, imaging is key. X-ray, CT, MRI, maybe myelography, CSF sometimes. Treatment is supportive care, managing symptoms like spasticity, extensive rehab, and treating the underlying cause if possible, REA surgery for compression.
Okay. Related to spinal issues is cauda equina syndrome.
Right. The cauda equina, horse's tail, is that bundle of nerve roots in the very bottom of the spinal canal, below where the spinal cord ends. Syndrome occurs when these roots get compressed.
Usually by a big disc herniation.
That's the most common cause, yeah. But also trauma, tumor, inflammation, spinal stenosis. Mix of motosensory deficits in legs. Key feature is saddle anesthesia, numbness in the buttocks, perineum, inner thighs. Often early bladder bowel incontinence or retention, impotence, absent ankle reflexes, maybe okay knee reflexes, sensory loss below L45. It's a neurological emergency.
Needs urgent treatment to decompress those nerves.
Absolutely. Prompt surgery is often needed to prevent permanent bladder, bowel, or sexual dysfunction.
Critical to recognize, which leads into neurogenic bladder.
Basically, bladder problems caused by nerve damage anywhere along the control pathway, sensory nerves from the bladder, motor nerves to it, spinal cord centers, brainstem, cortex.
Leading to retention, incontinence?
Can be either or both, or an automatic bladder that empties reflexively. Depends entirely on where the neurological lesion is. The type of bladder problem gives clues about the underlying neurology.
Another example of complex neurological control. Then peripheral neuropathy.
Damage to nerves outside the brain and spinal cord. Can affect one nerve, mononeuropathy like carpal tunnel, several individual nerves, modern neuritis multiplex, or many nerves symmetrically, polyneuropathy like in diabetes.
Causes. Loss.
Huge range. Acquired causes,
Yeah.
metabolic diabetes, endocrine, nutritional deficiencies, B12, toxins, tumors, infections, immune disorders, vascular issues, also congenital genetic causes.
Symptoms. Motor, sensory,
It
autonomic.
can be any combination. Motor, weakness, cramps, wasting, sensory. Numbness, tingling, burning pain, loss of sensation, often glove and stocking pattern in polyneuropathy. Autonomic, affecting heart rate, BP, digestion, sweating, bladder, common in diabetes.
Very common, very varied. Next up, myasthenia gravis.
An autoimmune neuromuscular disorder. Key feature: muscle weakness that gets worse with activity, improves with rest. Fatigability.
What's the mechanism?
The body makes antibodies that attack acetylcholine receptors at the neuromuscular junction where nerves talk to muscles. disrupts the signal transmission.
Clinical picture often starts with eyes.
Frequently, yes. Droopy eyelids, rhopitosis, double vision, diplopia. Weakness often descends. Face, swaying speech muscles, neck, limbs. More proximal usually. Gets worse through the day. Importantly, no sensory loss. Reflex is usually normal. Can be linked to thymus gland problems or thyroid issues.
Diagnosis. Tests.
Clinical picture is suggestive. Pharmacological tests. Anticholinesterase drugs like tensilon temporarily improve strength. Blood tests for acetylcholine receptor antibodies, electrophysiology, repetitive nerve stimulation, single fiber EMG, chest imaging for the thymus,
Treatment.
anticholinesterase meds to boost nerve signals, immunosuppressants like steroids to calm the immune system, plasma exchange or IV egg for severe flares. Thymectomy, removing the thymus, can help some patients.
A fascinating autoimmune condition affecting muscle function. The source then talks about wasting of small muscles of the hand. Lots of potential causes for that.
Yes, hand muscle wasting points to several possibilities depending on the pattern. Median nerve issue, like carpal tunnel, affects the thumb side, the nerve eminence. Ulnar nerve lesion affects the little finger side, hypothenar, and finger spreading squeezing muscles.
Okay, specific nerves. What else?
T1 nerve root lesion, or damage to anterior horn cells at T1 level, spinal cord, can cause widespread hand wasting. Motor neuron disease often starts with hand weakness wasting. Syringomyelia, cyst in spinal cord, can hit those cervical motor neurons. Cervical spondylosis, neck arthritis, tumors compressing nerve roots, brachial plexus injuries, even a cervical rib or lung apex tumor, Bankos can do it. Plus, just severe systemic illness can cause general wasting.
So the exact pattern of wasting and any accompanying sensory or reflex changes are key to figuring out the cause. Now, subarachnoid hemorrhage, SAH, bleeding around the brain.
Bleeding into that space between the brain membranes, most common cause by far is a ruptured cerebral aneurysm. Less often AVMs, hypertension, bleeding disorders, trauma.
Classic symptom.
Sudden severe headache. Worst headache of my life.
Mm.
Often with nausea, vomiting, neck stiffness, light sensitivity, maybe loss of consciousness. Can have focal signs or cranial nerve, cranial third nerve causing pupil changes. Signs of meningeal irritation, neck stiffness, Koenigs-Brzezinski's are usually present.
Diagnosis. CT scan.
Non-contrast CT brain is the first step, usually shows the blood. If CT is negative but suspicion is high, lumbar puncture to check CSF for blood, then angiography, CT or conventional, to find the source, especially looking for that aneurysm.
Complications can be bad.
Very serious. Rebleeding, vasospasm, artery narrowing causing stroke later, hydrocephalus, fluid buildup, seizures, sudden death. Prognosis is guarded.
Treatment. Secure the aneurysm.
Medical management, bed rest, BP control, pain relief, then definitive treatment to prevent rebleeding, either surgical clipping of the aneurysm or endovascular coiling via catheter.
A true neurological emergency. Next, ataxia, problems with coordination.
Exactly. Incoordination of voluntary movement without significant weakness can affect limbs, gait, speech, eyes. 3 main types based on cause.
Okay, what are they?
Cerebellar ataxia. Damage to the cerebellum. Causes limb clumsiness, trouble with rapid alternating movements, idiotokinesia, overshoot, rebound phenomenon, nystagmus, jerky eyes, slurred staccato speech, often low muscle tone, hypotonia, unsteady, wide-based gait, like being drunk. Includes hereditary ataxias like Friedrich's and Marie's.
Okay, cerebellar. What else?
Sensory ataxia, loss of position sense, proprioception from peripheral nerve or spinal cord damage, leads to unsteady stamping gait, much worse with eyes closed, positive Ronberg sign, because they rely on vision to compensate.
Right, and the third?
Vestibular ataxia, problem in the inner ear balance system or its brainstem connections, presents with vertigo, spinning sensation, nausea, nystagmus, imbalance, often less affected by eye closure than sensory ataxia.
So different types of incoordination depending on what part of the balance motor system is hit. The source then mentions the extrapyramidal system.
This is a network involved in modulating movement, influencing tone, posture, automatic movements distinct from the main voluntary motor pathways. Pyramidal system includes structures like the basal ganglia.
Functions, and what happens when it goes wrong.
Helps filter motor commands, regulate tone, involved in automatous emotional movements. Lesions cause movement disorders. Involuntary movements, tremors, chorea, athetosis, dystonia, changes in muscle tone, usually rigidity except maybe chorea, and sometimes changes in emotional expression.
So it's like the quality control and the background adjustment system for movement, which leads us to Parkinsonism, a classic extrapyramidal disorder.
Absolutely. Characterized by that triad, resting tremor, rigidity, and bradykinesia, slowness. Underlying problem is loss of dopamine-producing cells in the substantia nigra, part of basal ganglia, leading to a dopamine-acetylcholine imbalance.
Most common cause is Parkinson's disease itself.
Idiopathic Parkinson's disease, yes.
Yeah.
But Parkinsonian symptoms can also come from post-encephalitis, atherosclerosis, Wilson's disease, toxins, meds, tumors, trauma.
Can you describe the triad symptoms a bit more?
Tremor, usually rushing, cool rolling, improves with action. Rigidity, increased tone, felt as lead pipe, smooth, or cogwheel, jerky resistance when moving a limb passively. Bradykinesia, slowness initiating and executing movements, reduced automatic movements, less blinking, masked face, no arm swing when walking, soft monotonous speech.
Diagnosis is clinical, no specific test.
Primarily clinical diagnosis for idiopathic Parkinson's. Investigations mainly rule out other causes. Treatment aims to boost dopamine. L-Dopa, often with carbidopa cinnamide, dopamine agonists. Other drugs like anticholinergics, amantadine can also help manage symptoms.
A major neurodegenerative condition. Then there's chorea, different kind of movement.
Very different. Chorea involves involuntary, brief, rapid, irregular, jerky, dance-like movements. Can look semi-purposeful, sometimes pseudo-purposive. Neurochemically, thought to involve too much dopamine relative to acetylcholine. Can be idiopathic, senile chorea, post-encephalitis, vascular, like hemiplegia, they're very wild, flingy movements on one side, toxins, hereditary, Huntington's chorea, autoimmune, rheumatic synonyms, chorea after rheumatic fever.
Clinical picture, besides the movements.
Often associated with hypotonia, low muscle tone, maybe emotional changes. Different types have specific features. Rheumatic chorea, Huntington's, progressive dementia too, hemiplegia.
Treatment depends on the cause.
Yes. Treat rheumatic fever for that type. Dopamine blockers can help control movements. Huntington's management is complex, addressing motor, cognitive, psychiatric issues. Hemiplegia might respond to dopamine blockers or sometimes surgery.
Okay. And briefly, athetosis and dystonia.
Athetosis? Slow, writhing, continuous involuntary movements, often more distal, finger toes, snake-like dystonia. Sustained involuntary muscle contractions causing twisting movements or abnormal postures, often neck, trunk, proximal limbs. Both involve abnormal muscle tone.
A whole spectrum of involuntary movements. Now, headache, extremely common.
Defined as pain from eyebrows to back of head. Several structures can cause pain. Skull covering, artery sinuses, nerves, meninges, source lists causes. Vascular migraine, hypertension, arteritis, toxins, traction, tension headache, meningeal irritation, meningitis, muscle contraction, neuritis, neuralgia, referred pain from neck, sinuses, etc.
Lots of types. Let's focus on migraine.
Recurrent attacks, often throbbing headache, usually one-sided, sometimes preceded by an aura. Genetic link, maybe certain personality types. Mechanism involves complex vascular neural changes, initial vasoconstriction, then vasodilation inflammation maybe.
Phases of a migraine attack.
Often starts with prodrome, mood energy changes days before. Then aura, transient neurological symptoms, visual usually, flashing lights, zigzags just before headache. Then the headache itself, throbbing, moderate, severe, hours, days, worse with light sound activity, often nausea, vomiting, followed by post-headache phase, fatigue.
Types, classic versus common.
Classic has aura, common doesn't. Variants exist like hemiplegic migraine. Cluster headache is different, severe, brief, one-sided pain around the eye, in clusters with autonomic signs like tearing.
Treatment, acute versus prevention.
Acute attack. Rest, analgesics, triptans, antiemetics. Prevention, between attacks, beta blockers, calcium channel blockers, antidepressants, etc. Status migrainosus is a prolonged severe attack needing more intensive treatment.
Debilitating condition for many. Now, myopathies, problems with the muscles themselves.
Yes, primary muscle fiber degeneration, but the normal nervous system, classified as idiopathic, like muscular dystrophies, inflammatory polymyositis, metabolic, endocrine.
Progressive muscular dystrophy, like Duchenne. Clinical picture.
Usually starts in childhood, 10 years. Family history, often positive. Progressive weakness, symmetrical proximal distal muscles, commanding scapula, pot belly, lordosis, waddling gait, Gower's sign, using hands to climb up legs. No sensory loss, no bladder issues. Duchenne is more severe or rapid than Becker type.
Investigations, muscle enzymes, biopsy.
Yes, check urine creatine, creatinine. Serum enzymes, CK, often very high. EMG shows myopathic changes. Muscle biopsy confirms diagnosis.
Treatment, mainly supportive.
Largely supportive. Genetic counseling. Vitamins ATP often tried but limited effect. Physiotherapy crucial to maintain function. Causes death, often respiratory failure or heart problems. Cardiomyopathy.
Okay, multiple sclerosis, MS. Autoimmune attack on myelin in CNS.
Exactly. Inflammation and demyelination in brain and spinal cord, white matter. Cause unknown, likely autoimmune plus myor up viral trigger. Affects young adults, 20 to 50. More women.
Clinical pictures varied. Relapsing remitting course.
Highly variable. Onset acute or gradual. Often relapses and remissions. Can affect mentality, euphoria sometimes, speech, slurred staccato, cranial nerves, optic neuritis common, facial eye movement nerves, motor, UMNL signs like weakness, spasticity, sensory numbness, tingling, Helmholtz sign, cerebellum, ataxia, tremor, nystagmus, bladder bowel sexual function.
Investigations. MRI is key.
MRI is very important for showing characteristic plaques, lesions. CSF analysis, oligoclonal bands, IgG index, visual evoked potentials, VEPs, check optic nerve function.
Treatment. Steroids for relapses. Disease modification.
Acute relapse is treated with high-dose steroids. Long-term treatment aims to prevent relapses using disease-modifying therapies, like interferon, azathioprine, many newer agents now. Symptomatic treatment manages fatigue, spasticity, pain, bladder issues, etc.
Complex autoimmune disease. Now, epilepsy. Recurrent seizures.
Yes, recurrent unprovoked seizures, paroxysmal brain dysfunction, motor, sensory, psychic, autonomic with abnormal EEG activity plus altered consciousness, can be idiopathic, unknown cause, or symptomatic due to underlying brain issue, trauma, tumor, stroke, infection, metabolic problem, etc.
Seizure types. Partial versus generalized.
Generalized involve both brain hemispheres from start. Tonic-clonic, grand mal, absence, petit mal brief staring spells, myoclonic jerks, atonic drop attacks. Partial focal, start in one area. Simple, no loss of consciousness. Complex, impaired consciousness. Partial seizures can sometimes spread and become secondarily generalized.
Investigations. EEG. Brain scan.
EEG is crucial to look for epileptiform activity. Brain imaging, CT/MRI, to rule out structural causes. CSF if infection suspected. Lab tests for metabolic causes.
Treatment. Anti-epileptic drugs.
General measures. Avoid triggers, safety. Anti-epileptic drugs are the mainstay choice, depends on seizure type. Surgery might be an option for drug-resistant focal epilepsy.
Okay. What about status epilepticus? Continuous seizures.
Yes, prolonged seizure, 5 minutes, or recurrent seizures without recovery in between. Medical emergency can cause brain damage, exhaustion, often triggered by suddenly stopping anti-epileptic meds.
Clinical picture, usually generalized convulsions. Treatment is urgent.
Often generalized tonic-clonic, yes. Treatment is immediate. ABCs, airway breathing, circulation, IV anti-epileptics, benzodiazepines, lorazepam first, then phenytoin or phenobarbital. May need general anesthesia if resistant.
A critical situation. Coma. State of unresponsiveness.
Profound unconsciousness. Unaware of self-surroundings, unarousable, caused by dysfunction of the RIS, brainstem arousal system, or widespread damage to both cerebral hemispheres.
Causes. Intracranial versus extracranial.
Intracranial. Trauma, tumor, stroke, infection, epilepsy, extracranial. Toxic, drugs, alcohol, hypoxischemic, lack of oxygen blood flow, metabolic, diabetes, liver kidney failure, endocrine, fever.
Diagnosis. Glasgow Coma Scale. Exam. Tests.
Assess level of consciousness, GCS. History is possible. Examine vitals, breath odor, skin, pupils. Look for lateralizing signs. Investigations. Blood tests, metabolic, toxic, brain imaging, CT/MRI. Maybe lumbar puncture.
Treatment is supportive and treat the cause.
Primarily, yes. Maintain vital functions, prevent complications, aggressively treat the underlying cause of the coma.
Okay. Facial nerve palsy. Weakness of facial muscles.
Paralysis of muscles on one side of face. See encephalitis. Remember anatomy. Motor to face. Taste, front 23 tongue, parasympathetic to glands. UMNL lesion causes weakness only in lower face, contralateral side. LMNL lesion causes weakness of entire face, ipsilateral side.
LMNL can happen at different spots. Pons, nerve exit, canal.
Yes, nucleus and pons, cerebral-pontine angle, facial canal. Bell's palsy is the common idiopathic LMNL, likely viral inflammatory swelling in the canal near the exit. Presents acutely with full facial weakness, maybe pain behind ear, altered taste hearing.
Treatment for Bell's. Steroids. Eye care.
Usually corticosteroids, maybe antivirals. Crucial to protect the eye if closure is incomplete. Artificial tears, patching. Physiotherapy helps. Surgery rarely needed unless for other causes.
Got it. Trigeminal nerve. CNV. Sensation to face, chewing muscles.
Exactly. Lesions cause sensory loss in its distribution. V1, V2, V3 branches. Weakness of chewing muscles, jaw deviates towards weak side. Loss of corneal reflex.
Intrageminal neuralgia. Tic douloureux. That awful pain.
Yes. Sudden, severe, electric shock-like facial pain along a trigeminal branch. Often triggered by touch, chewing, talking. Excruciating. More common in older adults, women. Diagnosis is clinical. MRI may rule out compression MS.
Treatment. Meds first.
Medical treatment first. Anticonvulsants like carbamazepine are mainstay. Phenytoin, clonazepam also used. Surgery, alcohol injection, microvascular decompression if meds fail.
Okay. Briefly, visual pathways. Light reflex, accommodation.
Visual pathway, retina, optic nerve, optic chiasm, nasal fibers cross, optic lateral geniculate nucleus, thalamus, optic radiations, visual cortex, occipital lobe, light reflex, light optic nerve, brainstem, oculomotor nerve, pupil constricts, direct and consensual. Accommodation near focus, pupil constricts, lens thickens, eyes converge.
And lesions of the visual pathway cause specific field cuts.
Yes. Optic nerve lesion, blindness in that eye. Chiasm lesion, bitemporal hemianopia, lose outer halves. Optic tract radiation cortex lesion, contralateral homonymous hemianopia, lose same half field in both eyes. Pattern tells you where the lesion is.
Very logical. Sciatica, pain down the leg.
Pain radiating along the sciatic nerve path, back, buttock, back of leg, foot. Common causes: lumbar disc prolapse, compressing nerve root, lumbar spondylosis, arthritis, pelvic tumor, nerve inflammation, neuritis, for example, in diabetes.
Clinical picture. Pain may be weakness, numbness.
Radiating pain often worse with coughing, bending. May have signs of nerve root compression, weakness in specific muscles, reduced ankle jerk, sensory loss and dermatome, back pain common.
Investigations. Imaging. Treatment.
X-ray, CT, or MRI of lumbar spine, usually. Treatment: NSAIDs, muscle relaxants, physiotherapy. Surgery, decompression, if conservative treatment fails or severe deficits.
Common problem. Finally, meningitis and encephalitis. Infections of CNS coverings and brain itself.
Meningitis, inflammation of meninges, acute pyogenic, bacterial high neutrophils in CSF, or subacute lymphocytic, TB, viral fungal high lymphocytes in CSF. Infection via blood or direct spread, classic signs: fever, headache, vomiting, neck stiffness, photophobia, positive Kernigs-Brzezinski's. Can cause neurological deficits, seizures, diagnosis via lumbar puncture, CSF analysis. Treatment: prompt antibiotics for bacterial antivirals if relevant, supportive care, encephalitis, inflammation of brain tissue itself. Primary virus directly attacks CNS or secondary spread from elsewhere. Presents with flu-like onset, then neurological signs, altered consciousness, focal deficits, seizures, maybe meningeal signs too. Serious infections needing urgent attention. Wow, we have covered an incredible amount of ground today, from defining hemiplegia and UMLN versus LMNL.
Through the myriad causes, vascular being key, but also congenital, inflammatory, tumors, degenerative.
To how it presents differently depending on the lesion level, cortical, subcortical, capsular, brainstem, spinal. Not forgetting complications, investigations, and the wide range of treatments, from general care to highly specific interventions like thrombolysis or surgery.
It truly underscores the nervous system's complexity, doesn't it? How localized problems can have such far-reaching effects.
Absolutely. It's a testament to how interconnected everything is.
So, considering all these intricate pathways we've discussed, what does this deep dive into hemiplegia really tell us about the brain? Maybe about its surprising ability sometimes to compensate, but also the devastating consequences when even small parts of its delicate circuitry are disrupted.
It's a powerful reminder, isn't it,
Yeah.
of that constant, silent activity within us, controlling every single move and sensation.
It really is. Well, thank you so much for joining us on this very detailed exploration. We hope it's given you a clearer picture of hemiplegia and many related neurological conditions. Perhaps something to think more about.
Indeed. Thanks for listening.